Let's move on to the zona glomerulosa and mineralocorticoid function. Now remember that when we're talking about mineralocorticoids or even corticosteroids, we're talking about using a steroid receptor. If you remember from your pharmacology lectures way back at the beginning, when we were looking at receptors, there are 5 major types of receptors. Steroid receptors are intracellular receptors, and so the drug, because it's lipophilic, can cross the membrane easily, and that's how the medications or the hormones work. Now, if the steroid binds to the receptor inside the cell, it has to send a message into the nucleus. It does so through something called an MRE, or mineralocorticoid response element. This MRE is part of the DNA molecule. The MRE exerts its effects through DNA, and you have production of certain enzymes. Now, the aldosterone agonists are part of the renin-angiotensin system, and they have a very strong salt-retaining activity, just like endogenous mineralocorticoids. So aldosterone agonists are also considered mineralocorticoids as well as diuretics. A good example of a mineralocorticoid is Florinef or fludrocortisone. Structurally, it's very similar to cortisol. It has moderate glucocorticoid activity and very strong mineralocorticoid activity. It is involved and can be treating cerebral salt wasting syndrome. It can be used in Addison's disease. It can be used in this disease called POTS, or paroxysmal orthostatic tachycardia syndrome. And it's also sometimes used in geriatric orthostatic hypotensive syncope. So what we're doing here is we're retaining salt so that the blood pressures are a little bit higher, and it prevents the drop in blood pressure that geriatric patients have when they stand up. Spironolactone is a diuretic. We discussed it already in the hypertension section of pharmacology, but we also use it as its mineralocorticoid function to treat hirsutism. So it has mild androgen and mild mineralocorticoid activity. Let's move on to the zona fasciculata. This is where glucocorticoid production is occurring. Now, glucocorticoids also enter the cell as a free molecule. It doesn't need to be converted because it's already lipophilic. It binds to the intracellular receptor or other proteins and then enters into the nucleus as a complex. Now, instead of an MRE, it binds to a GRE, or the glucocorticoid response element, which is still also a portion of the DNA. The GRE regulates gene expression and transcription for its various functions. Now, when we use synthetic glucocorticoids in patients, we have side effects. That metabolic effect can be gluconeogenesis, lipolysis, and reduced subdermal fat. Morphologic changes can have lipid deposits in certain spots, such as the face, the neck, and the shoulder. So I want to go over that just again so it's clear. Reduced subdermal fat refers to, say, the back of the skin. So people will have parchment-like skin when they're given synthetic glucocorticoids for a long time. People who are given synthetic glucocorticoids will have more fat in the face, shoulder, and neck. So I say that they have a moon face. They have a round, kind of full face, but they have thin parchment-like skin. There are some catabolic effects as well. Protein catabolism and tissue wasting and osteoporotic effects are all part and parcel of glucocorticoid excess activity. So in other words, patients who are placed on synthetic glucocorticoids can have protein wasting and reduction of muscle mass, and osteoporosis is a major concern, and premature bone fractures is a major concern on people who are taking synthetic glucocorticoids for a long time. Side effects can also be immunosuppressive as well. Cell-mediated immunity can be affected by long-term glucocorticoid use. For example, lymphocyte-dependent infections can become more rampant, and so you have to be very careful of patients developing severe viral infections or increased susceptibility to viral infections. Renal function can be compromised. Remember, cortisol is normally required for water excretion. Anti-inflammatory effects are actually I wouldn't call it necessarily a side effect, it's actually the effect we're looking for. There's often a dramatic suppression of multiple markers. That's often why we use synthetic glucocorticoids in high doses in the first place. There's some neuropsychiatric issues. Excess cortisol causes giddiness and euphoria, and synthetic cortisol derivatives can cause that same kind of behavior change. The prototypical synthetic glucocorticoid is prednisone. It has a long half-life, it has quite good membrane penetration, and it's often used in acute inflammation in most disease states. It's often a steroid replacement therapy as well for people who have adrenal suppression. Dexamethasone is another synthetic glucocorticoid. It has an even longer half-life than the original prednisone. It has even better membrane presentation. It is often used in cancer chemotherapy as part of an adjunctive treatment regimen. Triamcinolone, beclomethasone, budesonide are other glucocorticoids. Beclomethasone is readily penetrating the respiratory mucosa, so we often use it in pulmonary inhalers. Let's take a look at glucocorticoid synthesis inhibitors. Now, this is a drug or set of drugs that we use to actually reduce excess endogenous cortisol production. Now, interestingly enough, ketoconazole you might recognize as an antifungal medication. We do use it in adrenal adenoma, breast cancer, and prostate cancer, and it is also used in hirsutism for the treatment of excess cortisol levels. Metirapone is another medication that we use in glucocorticoid pharmacology. It inhibits synthesis of cortisol. We actually use it more for diagnostic testing rather than actual therapy. Other agents block conversion of cholesterol to the precursors of cortisol and other endogenous steroids. It is used in steroid-producing cancers to prevent excess steroid in the body. The zona reticularis function and adrenal androgens has been covered in another lecture, so I won't go into too much detail here.